All right, everybody, welcome to class tonight. We had to pre-record this class because of the hurricane and all that jazz. So, um, myself and three classmates are here. So we're gonna go ahead and rock on and make sure you guys get the information. You can go over it. CPR, kind of seems pretty simple. Most of you probably don't. Probably most of you probably already have CPR, but it's one of those things where we need to make sure we cover it in a little bit more condensed context and make sure everybody is aware of some of those things. Some with National Registry and those types of tests, they go by the American Heart Association standards. So if you had it or it's been a while since you really had it and paid attention, we want to make sure that you pay attention to these because you could see those on a National Register test or another test using these guidelines. So a lot of things that we talked about recently, like with airway and those types of things, they play right into CPR. So, CPR is obviously a pretty big deal. It's not, we have a lot of stuff going on. There's a lot of things that we have to deal with, with managing a cardiac arrest patient. So we want to make sure that we are putting together all those different aspects of airway, breathing, and circulation, and putting those to work. So again, hopefully, it's something that we can work through and we can try to get the patient to respond to our treatment. But, a lot of times, I mean, because again, we have a lot of different variables there. We have patients who are children who don't have coronary artery disease, you know, because they ate a bunch of cheeseburgers for 50 years, right? They are, there's somebody who, uh, took a baseball to the chest, right? Or was in an accident, or again, that 25-year-old who was in an accident, who took some trauma to the chest. That might be why they're in cardiac arrest, and so um, we have to ensure that we're looking, past all those things and making sure that we're treating the patient. When we do that, it's we use the circulation airway breathing, which is kind of what it got changed to, was CAB, and essentially just making sure that we are getting that blood flow moving throughout the body. But again, that airway and breathing is not necessarily second fiddle. We have to do that, like we talked about the other day. We have to make sure they have a good patent open airway and that those breaths are able to go in and out. And if we can't do that, we have no viable patient, right? We can't do much without that. So just remember the circulatory system consists of the pump, which is the heart, a network of pipes, which is the blood vessels, and then the blood is the fluid in there. The the heart, like we said before, is located in the center of the chest, more in the center of the chest than to the left. It is a little situated a little bit at an angle, so it sits more to the left than the right. However, it's one of those things that just to remember when we're looking at doing chest compressions and all those other different types of things. We want to make sure we understand where the heart actually is and we literally are pushing down on that chest plate and pumping on the chest. I mean, pumping on the heart manually. So again, each chamber of the heart is called an atrium, the upper chamber. Okay, so you have the two atriums, left and right atrium, and then the lower chambers are called the ventricles, so left and right ventricle. The four chambers work in a well-ordered sequence, okay, up and down, and it's basically essentially by electrical fibers that are stationed throughout the heart, and those things make that heart fire off and beat in that certain manner. If they don't do that, then we have a problem. Okay, so if that electrical system is messed up, then we have the sequence issue, right? So it's an electrical problem. Now we also have stuff we talked about, pipes and pumps, right? So if that pump or that pipe also has some type of clog in it, we can't get the blood to go where it needs to go. So that would be a mechanical problem. So our big thing with uh, the mechanics of it is we really can't do a whole lot about that. Okay, we can't go in and fix that. So it's important for us to remember that we need to, you know, especially with AED usage and things like that, we try our best to utilize that AED whenever we can, because that's really the main thing that we're going to be able to fix is going to be that electrical problem. A lot of times with some of those traumatic arrests and some of the ones, especially the younger patients, are going to be an electrical problem. All right. Um, of course, there are older patients that have that issue as well, where they have just a deteriorating, cardiac tissue, and so you have the uh, essentially the pacemaker of the heart, which is with those little nodes, okay, SA and AV nodes in there, sinoatrial and atrioventricular nodes that actually fire those sequences, um, just deteriorate. Just like anything else, they start to wear down, and so. But again, using the AED is for that electrical problem to try to reset it and see if it'll hit the reset button, see if it'll start back. Um, and then again, mechanical issues, it's tough. It's just tough to deal with. So as you can see there, kind of a breakaway section of it. Um, it has the your main vessels there: aorta, pulmonary artery, pulmonary veins, the right atrium. Sorry, the right atrium, left ventricle, right ventricle from the outside. What we were just talking about with those nodes, if you can kind of look up there at the left where it says left pulmonary artery and it's pointing to that area, just below that, um, you'll have that sinoatrial node, or the SA node. So sinoatrial, right? Atrium. And then you'll have your atrioventricular, so ventricle, right? So the other one will be down there on the bottom side, and that's where those two sequences fire from. So that's why we have two pads on our AED, so that we can shoot that arcing of electricity across the heart and help to restart it. So again, the arteries carry blood away from the heart at high pressure. That's why we tend to worry about those arteries when they bleed more, because that blood is going to be coming out faster, right, and more volume. So smaller arteries eventually branch into capillaries and the smallest pipes down the circulatory system. So if you look at your pinky and it's pink, okay, or if you look at your nail bed and it's pink, that's because there's a capillary bringing blood all the way down there to that very, very last tip of your finger. Okay, same with your toes, right? So, and then all the way up to the top of your skin and all that to make it, to keep the heat regulated and all that stuff. We talked about skin not too long ago. So, veins are thin wall pipes that carry blood back to the heart. So when I mentioned this before, we give IVs to people, right? And we want to give somebody medicine through an IV. We want it to go get pumped out to the rest of the body. We want it to go where it needs to take place. So we send it through the vein up to the pump, and the pump will push it out, right? So veins carry blood back to the heart. The four major artery locations: the neck, which is the carotid arteries on both sides; the wrist, the radial arteries; the arm is the brachial artery up here in the like if you're going to flex your bicep, make a muscle, it's going to be between your bicep and your tricep, and it'll be right there near where your humerus bone, and you can kind of feel it right in there. That's also our pulse point. We talk later about babies, okay, or infants. That's where we're going to check our pulses in our babies and infants, okay, the brachial artery. And then the groin is the femoral artery, okay. It's actually descends down and branches out there, from the at each crease of the hip, essentially. So if you looked at it on a cross section, it would be right there, kind of where your hip flexes at. That's where it goes through. So a pulse is generated when the heart contracts and sends a pressure wave through the artery, and that's how we know that's each time the heart is pumping out. That's why we count that. We get that heart rate. And there's an example just of the locations where you can see it. So blood has several components: plasma, red blood cells, white blood cells, platelets. Platelets are important because they start the blood clotting process. The white and red blood cells help to carry things, so they're really like the transport arm. And so and the white blood cells help to, like it says, devour bacteria and other organisms in the blood. So the blood kind of stays clean. It's kind of the cleaning agent of the blood. And there's just a cross section of blood, just kind of give you an idea of what, how it's made up. 45% of blood cells, and then 55% of plasma. So cardiac arrest. What does cardiac arrest mean? Right? Cardiac arrest, everybody thinks of, if somebody's unconscious, they're having a heart attack, right? Or if they grab their chest and they say their chest hurts or whatever, they're having a heart attack. And that's actually more appropriate. Okay. So cardiac arrest is the actual arrest of the heartbeat, right? So we can't, the heart isn't functioning at that time. It's arrested, it's stopped, right? And a heart attack, just the general term heart attack, is typically when you have a patient who is able to tell you, hey, my chest hurts, I'm having difficulty breathing, I'm sweating, that sort of thing. When they can tell you all that, and they're a viable alert patient, that's generally what we refer to as a heart attack. But the cardiac arrest part is different. That's when your patient is not breathing, doesn't have a pulse, and that's cardiac. That's true cardiac arrest. Okay, so no blood flow at all. Without a supply of blood, the cells of the body will die. I mean, it needs everything. All these different pieces and parts play a role in everything's survivability. So we need all those different systems in the body to help us uh, have a strong and healthy blood supply. And as you can see there, about 4 to 6 minutes, and we start to have brain tissue death. So, causes of cardiac arrest: heart and blood vessel disease, the respiratory arrest. So again, that's one of those where it's maybe drowning, just a low oxygen atmosphere, don't have enough oxygen in the air to breathe. So if somebody was, like, say, a worker down in a manhole, they're breathing some other gases or something like that, and they don't have enough oxygen. So numerous things that could happen there, but essentially they stop breathing first, and then that cycles into choking would be one of those, and then it goes down into that. So medical emergencies such as epilepsy, diabetes, allergic reactions, electrical shock, poisoning, any number of things can contribute to that. Drug overdose, drowning, suffocation, trauma, and shock from massive blood loss. So again, if our we don't have enough volume of blood, so we've bled out too much, the pump can't it doesn't have enough volume to make things go around, right? And so we end up with very fast heart rates because our vessels are going, hey man, I need some, I don't, I'm, this is not enough for me to use. So the vessels will constrict to help push that faster, help push the blood along. And so when that happens, typically we have a pretty fast heart rate, and because the pump is also going, hey, come on, I need to work faster, I need to work harder, and it'll start pumping faster and harder, trying to get that through there. So again, that will essentially cause hypovolemic shock, low volemic shock. So a patient who's experienced cardiac arrest is unconscious and not breathing. Again, if you've ever had CPR before, that's essentially what defines that. Okay, cardiac arrest, no pulse, no breathing. That's all you need. There is no underlying anything. There's no other things you need to check or whatever. There's no pulse, no breathing. That's all we need. Okay, we're doing CPR. So we mentioned this earlier. They just put it in a different order. It's fine, but this is the new guidelines. Put airway, breathing, and circulation with the ABCs. They just put C in front of there, so they made it CAB. And so the cab is kind of focused a little bit more on circulation. This is also focused on the civilian side. So the layperson CPR, they started focusing more on having civilians do compressions more than doing breaths. But for us, it's all important, and we need to make sure that we are doing all of them appropriately. So, like we said the other day, we need to make sure that the airway is open. We do that by a couple of maneuvers: head tilt, chin lift, and the jaw thrust. Right? Remember we talked about lifting the jaw, pushing it forward, try not to move the head. So if we only use the jaw thrust, if we really suspect some kind of serious head or neck injury. So determine if the patient is breathing. We do that by look, listen, and feel. Right. We want to make sure that we are putting our ear down there. We're listening for and feeling for breathing on our face, and we're looking for the big one: chest rise and fall. Right. So when I see that chest rise and fall, if we don't have that, our patient's not breathing. Again, we don't have to go through jump through a bunch of the hoops. If they're not breathing, I mean, if we can do that and assess that about 10 seconds and realize that they're not breathing, then we're going to start rescue breathing. Okay. So circulation skills, again, we're checking for a pulse on that carotid artery primarily. If we're really concerned about cardiac arrest and making sure that they are alive enough, we're checking that carotid pulse. Okay. We're not going to be worried about, radial pulses or brachial pulses or anything like that. So again, if there's no pulse, we're performing chest compressions. That's all we need. So no chest rise, we're doing rescue breathing. No pulse, we're doing compressions. Both of them together, that's it. We're doing CPR, full blown CPR. So if we do have a pulse, however, and we're just not breathing, then we'll just do rescue breathing, one breath every 5 seconds, right? So CPR by itself cannot sustain life indefinitely. We're just doing what we can until we can get some of the right drugs on board, or again an AED, things like that. I can tell you, in my long career, I probably have like maybe 3 people that I know that were sure enough not breathing, no pulse, and we got them back with good rhythms, and they survived. They eventually survived. Um, so I've only had one that actually like Baywatch, like the dude woke up. All right, so this guy was clinically dead. He no pulse, no breathing, and before I left the hospital, he was talking to the nurse. Very, very, 0.5% rare. Okay, so don't expect that. That's not how it happens. Whatever you see in a movie is wrong. Um, it just does not work like that. So most of them are going to require extensive hospital stays. If they do recover, it's going to take, like I said, it really just depends. So, like I said, we have your ones that have your more like traumatic arrests and things like that are associated with something else, like a breathing problem or something. It's not really a heart problem. It's a breathing problem or something along those lines. Those people typically will recover and stuff like that in the hospital. But as far as seeing them open their eyes and start coming to and thank you and all that stuff in the back of the ambulance, ain't happening. But again, we need to start as soon as we can. Direct people to start it. If you're responding to the call and dispatch hasn't already done it for you, if they can say, hey, are they breathing? Yes or no? No. Check for a pulse. Do they have a pulse? No. Tell them to go ahead and start CPR. They don't have to have a card in their pocket or anything. Tell them to go ahead and start CPR. And that way we can, even though we might have a 5-minute response time or something, that's 5 minutes. We can already have blood flowing. So, and then of course the defibrillator uh, is for those electrical issues, and then medication that the paramedic will give them by standing order from the doctor will be able to speed up their heart or slow it down. They'll also be able to do a few things with their monitor that the AED will not do. And so if their heart is very slow, they can actually what's called pacing, so they can take the heart and manually make it beat how fast they want it to beat. So pretty neat stuff. And like I said, they do a lot of stuff by standing order from the doctor. So Chain of survival, just really, one of those things, just to think about how, how all this stuff works. And they put the chain of survival and then the pediatric chain of survival later, but it's early recognition. So all these things, all these chains, we need to have a good solid chain to make the best survivability chance for that patient. And so if you take away one of those links, the chain breaks, right? So, so if you look at all these different ones, they really play a role in that. And so, we fall into that, basic and advanced emergency medical care, right? For what we're talking about here. Um, we could, we could be the first ones to start CPR, like it says at the top, but we really want to make sure that we are, um, we're there and we're responding, appropriately and able to provide quality CPR and defibrillation. So that's why a lot of us have defibrillators on our fire trucks and cop cars and all sorts of different stuff at the mall and at the airport and everything else. So again, that's the chain. So when to start CPR, like we just mentioned, signs of death. I think we mentioned that the other day as well. Decapitation, rigor mortis, um, obvious signs of, you know, lividity, like we talked about, where they're turning purple, um, tissue decomposition, where, their skin and everything is just like falling off, like they've been submerged for a long time, that sort of thing. Those are obvious signs that we don't need to resuscitate them. Okay, we don't need to try to revive them. Okay, that's just obvious signs of death. We also mentioned this when we talked about DNRs and all that. When discontinue, um, spontaneous circulation, ventilation, comes back. So if we get that, and uh, they start breathing again, they have a pulse. Hey, fantastic. However, you need to expect it to go away. If we, again, with just CPR, we get them back, fantastic. That's awesome. You know what I mean? We'll put them in the recovery position. We'll monitor them, and hopefully they'll keep going on their own. Again, depends on what it is, right? So if it was a near drowning victim or somebody got electrocuted or whatever, and we come and we shock them, we do a few rounds of CPR, and all of a sudden we get a good pulse back, and get breathing back and everything. That's great. But especially in your um, sick patients, patients that have deteriorating diseases and things like that that contribute to their heart attack or their cardiac arrest. Generally, those patients you'll get a pulse back for a little bit and then they'll go away. So that may happen multiple times, but but that's what we're looking for is some type of spontaneous recirculation and breathing. And then if you have somebody that comes there that's higher level of training, equal or higher level of training, and you want to turn that over to them, that's when you would discontinue CPR yourself, but they may keep going. A physician orders you to stop, so that's kind of vague. Some guy in t-shirt and flip flops, comes up to you on the side of the road while you're doing CPR at a wreck or something, and or at the grocery store, you're doing CPR, and some guy walks up and says, "Hey, I'm a doctor, man. They're gone. You can hang that up." All right. You just need to politely go, "Sorry, sir. This is, we have a job to do, and unless you have some type of official credentials, something like that, you need to be able to prove to me that you're an actual physician, and that in this state, in this area, you know what I mean." So it's not just any doctor. Like the podiatrist doesn't get to just come out and come up and go, "Hey, they look dead to me, man. You can probably take a rest." No, it don't work like that. Okay, so it's not just any old doctor. Needs to be a physician that is in charge of that patient's care, or things like that. Okay. So and the next one would be a patient is transferred to a properly trained EMS personnel. So again, we're handing it off to an EMT and a paramedic or something like that, or a BLS truck. So it could be two basics. Maybe it could, and these days it could be an advanced EMT, and you're handing it off to them. So um, that would be the times where we would discontinue CPR. Um, Again, if you have obvious signs of death, and then if you're just so physically exhausted, I mean, we've got a lot of firefighters, in class, and so if I mean, if if you had to drag them through the building to get them outside, and you finally get them outside, you take all your stuff off, and you've been working in this fire for an hour, and you start doing CPR, and you're just like beat, you're dead tired, then it's gonna be tough. It'd be tough for you to keep going. So it's understandable that you may not be able to continue. So everybody has different fitness levels and everything else, but it's just one of those things where you have to make sure that um, you at least keep trying to do something for the patient. So we may not be able to physically keep pumping on their chest, but um, we're trying to still provide some type of care, or trying to speed up the process to get somebody else to come help you or whatever. Sorry, we're not just like we talked about with liability. We're not abandoning our patient, right? We have to be able to articulate why we did that. Like, I couldn't move my arms. You know what I mean? So external cardiac compression, the unresponsive patient, you kind of scan the chest. Like I said, look for signs of breathing, check for a pulse. We check for a pulse, and you don't have one, we're going to go right into chest compressions. All right. So no pulse, we start chest compressions, and then we'll start doing CPR with our chest compression, our 30 compressions and 2 ventilations for our adult patient. For the infant, same thing. We're looking for any of those signs of life. Sometimes tapping the feet, pinching the bottom of the feet a little bit will help to arouse the baby, just because they're a little more sensitive on their feet like that. So I wouldn't just shake them. Obviously, we don't want to shake babies, right? Like we would a big adult. So check for that brachial artery in the upper arm, okay, for a baby, and make sure they have a pulse there. Same thing. We're looking for chest rise. We may need to maybe put a hand on there and just kind of feel if their chest is rising. It's just so small and so shallow, we not be able to see it very well. So for babies, again, it's essentially we're going to hold them in our hand. Hold them in our arm, kind of like you're doing right here in this picture. To me, that's the optimal way of doing it. You can move around with them in your arms, and you can do everything you need to do. So we can do choking stuff here. We can do um, chest compressions, breaths. We can do everything from right here. So two fingers in the intermammary line, so right in between the nipples, right in the center of the chest, and straight down. We don't want to go straight. We don't want to move across. We want to go straight down, and that will give us our best compressions. Again, we're not going to go too deep on these, as definitely not nearly as deep as we would for adults. So on the child, it's essentially the same thing. We'll just use one hand instead of two. Larger children, maybe you need to use two. Just depends on the size of the child, but ultimately, one hand is usually pretty good for adolescent and younger. So one rescue adult CPR, like I mentioned before, 30 compressions to 2 ventilations. Okay, the 30 to 2 is for adult 1 and 2 rescuer is going to be 30 compressions and 2 ventilations. So again, nothing really changes with the 2. We're just going to make sure that we have somebody stays at the head the whole time, does breaths, and somebody is doing compressions, and we don't have to move around as much. And again, if you get tired, you got somebody right there you can swap out with, and you're just going to rotate around the head and take over. Usually when we do that, it needs to be pretty quick. We switch positions. If we do 30 compressions, if you'll start on 20. So if I'm doing on my 20th compression, I'll start speaking to my partner as I'm counting compressions. Usually it sounds something like 20 and 21, and let's switch on 30, something like that. And so I'm kind of slowing it down so he understands what I'm talking about. And then um, and that way I count out the last 10 or 5 or 10 or so compressions through speech, and then he knows, hey, on 30 we're switching, right? And so he'll give his 2 breaths, and then we'll switch. One rescuer infant CPR, again, same thing, 30 compressions, 2 ventilations. Again, the compression rate is going to be a little bit more for those. They don't need quite as much. they don't need to use quite as much depth, but they do need to ensure that we do at least 100 beats per minute, preferably a little bit between 100 and 120, so that we get because again, remember their heart rate is a good bit faster than ours naturally, so we want to try to match that. Then we give those 2 breaths, again, just enough breath to make the chest rise, and then we'll go back to our compressions. 2 rescuer infant is going to be 15-2 on our compression to ventilation ratio, and that's just because that rate of compression is a little bit higher, and we have 2 people there, and so it just doesn't take nearly as long for that to take place. So whenever we're doing that, we can do, when you have 2 people, sometimes it's actually, I mean, if you lay them down, it's probably the easiest with 2 people. And you see the 2 thumbs encircling hands, essentially just like if you were going to pick the baby up and put your hands underneath their armpits and raise them up. That's essentially the same way. So you put your thumbs, the pads of your thumbs on the center of their chest and press. So for those of you who are gamers, it'd be almost like you're holding a controller. So we're just going to be pressing straight down with our thumbs. And still the same thing, 15 compressions and then 2 ventilations. Just enough air to make the chest rise. Again, child CPR, 2 rescuer, very similar. We're just going to use that one hand. So whenever we do that, we're still going to we're going to go through our cycles of CPR, about 2 minutes or about 5 cycles of CPR is they kind of roughly match up. And so after that, with all of our patients, once we give those 5 cycles, we want to reassess and make sure that see if they have a pulse or there's a breathing or if they have any. Again, depending on what we're doing, right? So if we're doing choking or something, we want to check and see if there's anything in the airway or anything like that. But it's quick. It's just a quick thing. We're looking, listening, and feeling for breathing, and we're checking for a pulse, and then we're moving on. So signs of effective CPR. We talked about. We know when we're giving breaths that chest rises and fall. We know we're giving breaths efficiently, and the skin color changes. But for compressions, it's by that pulse point. So especially when you're doing 2 rescuer CPR, if you have if somebody's when they're doing compressions, the person at the head, if you'll check for a pulse while they're doing CPR, you should be able to feel a carotid pulse. Okay, so if not, you may have to coach them a little bit. Hey, let's go a little bit deeper, a little bit harder, something like that, and because especially when you start getting into round 5 and 6 and 10, and it's starting to get, your triceps are starting to burn and their shoulders are starting to burn and that sort of thing. Lower back starting to burn, knees are starting to hurt. Okay, because those things will happen, and whenever you start to get tired, you'll eventually start easing up on those compressions. So, um, like I said, a lot of times you'll get around the lips and the nail beds and things like that. You start to get cyanotic, which is what it's talking about when it talks about blue. And so whenever you have a cyanotic patient, we want to try to, we're trying to get that blood flowing. So if you start seeing their color improve, then typically you're going to, you're doing something. You're moving blood throughout the system. Broken ribs, it's kind of one of those things where it's understandable to kind of feel that way, but sometimes it's not. We mentioned this a little bit in the anatomy side the other night. It's not really. Usually you're not breaking ribs. The potential is there, and sometimes it does happen. Usually, if you're breaking ribs, you're probably doing your compression wrong, but it can happen. And you're not really going to know it's happening. You really can't tell the difference. But the other thing that you hear when you hear that cracking sound is actually the cartilage from the rib, to where the rib is connected to the chest plate, and at that joint, it's actually not hard fused. So it's not bone to bone. It's actually bone, cartilage, bone. Okay, so that's that's typically it popping out of that cartilage when you hear that. So that's one of those things. It's kind of disconcerting whenever you first start to do that sort of thing, but it's part of it. You're not really injuring your patient per se. They're going to have a sore chest for sure. It's something that surgeons can go in and work on if it's a little bit worse than usual or something like that, but not something that you really have to be super concerned about. So big thing, hand placement. Make sure your heel of your hand is on the sternum, and you're pushing straight down. So if you're a little bit farther back on one side or the other, you have that potential to, or if you lay your fingers down, you have the potential to push down on that rib and break it. But if you're right over the chest plate and you're pushing straight down, and you're got your arms locked out, you're not shifting your weight forward, then you should be good. Gastric distension. So essentially, when we we don't have our head tilt chin lift done correctly, or if we are giving too much air too forcefully, then a lot of times you will get gastric distension, which is air into the stomach. Okay, so just like blowing up a balloon, you push that air in there too fast and too hard, or too fast and too hard, then you will get it returned back to you, and usually with the contents of the stomach. Okay, are going to come up and out pretty forcefully. So I've seen it. Like I said, I think I told you guys before, I've seen it hit the ceiling in the ER over here in Poplarville before. So, you really got to, try to pay attention to that every so often. Especially if you're the one giving breaths. Reassess your airway. Make sure you can look at the stomach and see if it's moving up and down when you're giving breaths, that sort of thing. So look at the chest, see if it's rising every time, and not going in there. So regurgitation, it also you may not be so bad, but you will get you'll get vomitous or foreign bodies that will kind of make their way up. It just as it'll kind of just start to slowly push it up, so it may not be so forceful, but you'll start to come up into the airway and eventually into the mouth or into the throat, and so we have an issue potentially with blocking our airway. All right, so if you see that, turn the patient on the side. Try to get it out, suction if needed, and clear the airway before we keep doing what we're doing, because we don't have a open airway. We're really not doing much, right? Like we talked about the other night. So we definitely don't want the patient, that's what it's talking about, is aspirating, which is getting that vomitous, whether it's fluid or foreign bodies, into their lungs. Okay, so we don't want that to happen. We have run into big time infection, and of course just functionality of the lung. So again, you may force vomitous into the lungs with the next artificial ventilation. So we don't want to do that. So as soon as you notice that there's something in the airway, or it's not, you can notice as you're bagging that patient, or as you're breathing for them, that it'll get harder to breathe. It may get harder to bag. You'll get more resistance to it that's against the face. And so again, open the airway, check it out, suction if needed. So, creating space for CPR, we need to get those patients down off of beds and couches and recliners and all sorts of stuff, out of the vehicle if possible, and try to get them to a space where you can really work. We need to be able to work there, but the paramedic even more so needs to be able to work in that space. If they're in cardiac arrest, they're going to get tubed. If they have a viable airway to be able to be tubed, then more than likely the paramedic is going to attempt to tube an IV. Those they need some space for that. So try to think about a little bit, a couple steps ahead about that, and make sure you get them in a good location. Right off the bat, let's go ahead and find a landing spot for them and get them there, even if it's 2 rooms away or outside or whatever it is. Let's get a good solid location for them to be able to do some good patient care, and for us to assist them. All of us are going to be around them assisting and doing stuff, right? And then eventually we have to be able to transport them, so we're going to need to package them up some way in a backboard or a sheet or stretcher or whatever. So we want to be able to get that patient up and onto the stretcher soon so we can, again, get to a higher level of care quickly, right? So early defibrillation by EMRs, more than 70% of all hospital cardiac arrest patients have an irregular heart. So electrical rhythm called ventricular fibrillation, so VFib. This is one that is the primary rhythm that the AED is looking for, and or will respond to. And so if they are in VFib, typically you'll good chance that you're probably going to get a shock advised on your AED. So VFib is essentially the heart quivering, it's shaking, and it's not one end or the other, it's the whole heart is just shaking back and forth. So we want to, and because it's so disorganized like that, it's not able to flow blood at all. It's not, there's no actual movement of the blood happening. So we need to, like I said, shock it and hit the reset button, and hopefully those SA and AV nodes will start back again in the right sequence. Okay. So the AED, the AED, there's a ton of them out there. Several different manufacturers and types and colors and packaging and boxes and this and that. Storage containers and also all sorts of different stuff. Some of them are co-located with medical bags and trauma kits, and they have all sorts of stuff hanging off of them and everything else. But ultimately, they all basically work the same. Now you'd be hard pressed to find one with more than two buttons. You have a power button and a shock button, and sometimes you only have an on button. You just have a shock button. So the one on the bottom there, the life pack, is a really good one. You lift the lid on it, and it just starts telling you what to do. Usually the stuff is already pre-connected and all this other stuff. You don't have to plug anything in, nothing like that. You have to peel the stickies off the back of the pad and put it where it tells you to put it, and then it'll analyze and tell you what to do. So it seems like an eternity, but if you'll just wait, give it a minute, and just do what it says, take a breather, and make sure that you're putting your pads on right and all that stuff. So the early defibrillation is part of that adult chain of survival. It's one of those things where we need to assess our patient, make sure it really at any point. So if we've been doing CPR for a minute or two, or we've been doing it for 20 minutes, we're gonna as soon as we get the AED, we're gonna put it on there and let it analyze. So we'll do CPR right up until the point to where that thing says analyzing. When it says analyzing, don't touch patient, that's when we stop CPR. So there's no reason why the person putting on pads can't do that around you while you're doing CPR. It's not difficult. It's really not in the way typically. Depending on the size of the patient, sometimes they may kind of stretch over towards the center of the chest, but generally you can usually work around it. And the one on the left side of the patient, underneath the armpit there on the side, on the flank, it's out of the way. So should be no problem doing that. But once we do that, once we get those pads on, again, just follow the prompts on there and do what it asks you to do. Don't try to rush it. So again, like I said, this is kind of the first part of that. We're going to, as far as your CPR training, when we do skills, we'll go back over cardiac arrest management. That's one of your national registry skills for sure. And we will go back through CPR and AED, make sure that you guys are good to go with that. Most of you probably already have CPR, which is fantastic, and it's not gonna impede you in any way with your additional ones. And those of you who don't have it, we'll get you certification then. So the legal implications of CPR, advanced directives, living wills, like we mentioned the other night, or documents that specify the patient's wishes regarding the specified medical procedures. So if if there aren't any of those things in place, we're going to do CPR. It's going to be unfortunate. The family may be upset and all this other stuff, but if we don't have anything legally binding that says not to, we're going to act in good faith, right? We're going to act in good faith and inside of our scope of practice, and we're going to provide the best care possible until we are told otherwise, and or given the correct paperwork and all that stuff. So again, don't hesitate that. Don't hesitate to start CPR on a pulseless or non-breathing patient. Again, abandonment. We kind of touched on this a little while ago. Discontinuation of CPR without the order of a licensed physician or without turning the patient over to someone who is at least as qualified as you are. That's going to constitute abandonment. Okay, so you got to make sure that you're not just up and leaving that patient with Joe Blow, the citizen, because you need to go run down the road for a minute, whatever. You got to go do something. Um, and oh well, he'll be fine until somebody else gets here. No, you're going to get in big trouble. So again, kind of an overview of CPR. It's not nothing too crazy there. Again, for those of you who've had it, you probably uh, just to get a little quick refresher for you, there are um, you know, we kind of hit on some of the things that we'll talk about in the cardiac section with the sections of the heart and what those things do. It'd be good, in this chapter and then in that chapter too, to make sure that you understand that. That's a big part of how we treat when we go forward treating some of those cardiac patients. Um, make sure that you know your carotid, your artery locations, your pulse points essentially, and those pulse points are also places when we get into bleeding control. Those are areas that we can stop bleeding. Okay, so if we have distal bleeding, so bleeding below or towards the end down there, like say in the hand or something like that, we can put pressure on that, that brachial artery and slow the blood flow to the hand, right? So same way with the femoral artery, um, and not so much in the carotid, but nonetheless we may have to occlude that with wound packing or something like that. We'll get into that later, but that's those are things to be cognizant of. Yeah. So again, like I said, those are things that seem pretty simple. CPR is pretty simple, but for us, you have to understand. Just to give you some insight, if you've never been around that type of incident before, it's controlled chaos, and it can be real chaos if you don't watch it. So, um, bystanders, family, all that sort of stuff, you need to get them out of your way unless they're directly helping you. But ultimately, you have a lot of stuff going on, especially when the paramedic and the basic get there. They can do it by themselves. I'm sure they've done it before, but ultimately, if maybe one or two other people there, so maybe like four people total, is really what it really makes it go smoothly if you know what you're doing. When the paramedic gets there, there's going to be again, they're going to be intubating, so you got tubes and all sorts of different stuff. You have vomit and everything else there. Um, you have the trying to start an IV, so you can have blood and other fluids that are running around there. Somebody has to hold that bag usually of fluid. Um, at some point, they may right there on scene, they may start to push some type of drugs to help that patient, and so a lot of times you have to prep that drug into the needle, and it's two-part injector, and so a lot of times there's different types of medication being sprayed here and there, right, in the air. So you have to watch out that you don't get sprayed by medicine. I mean, there's, uh, like I said, somebody's doing compressions and all this other stuff. Somebody's bagging still, and so there's a lot of different things that's going on that you have to be aware of. If you know what's coming next, and this is where again it just takes doing it a lot of times. It's not something that we're going to necessarily we're not going to test you on, but it's one of those things where if you do it enough, go to these calls, elect to go there, ask to ride in the back of the ambulance, ask to help out in the back of the ambulance before they leave, that sort of thing, you're going to start to see what happens next. And again, you're not going to do those ALS, advanced life support things, but you can help to spike the IV bag. You can help to, you know, grab the, have certain things laid out on the intubation roll. You're not using those things, but if you can tear tape. An IV is going to need either a starter kit. It's going to have a certain type of tape and covering for the IV site. You can have that stuff laid out, unrolled. You can have things ready for them because that's very, it's a very tactile type skills there. They're having needles in their hands. They're having to set the needle down first, then take the line. So holding the line, all this other sort of stuff, bleeding the line out, all these little things that are not skills for you, but however make the whole thing run way more smoothly. When they don't have to set stuff down, it's cleaner. We don't have to set stuff down and put it on the ground or put it on the patient and all this other stuff. So especially given the environment, it's good to have some more hands to hold things, do stuff with, and makes the whole thing run a whole lot smoother. So that's it for tonight. This is again your CPR lecture. This is your for your class would be for Tuesday. Again, make sure that you're going through there, checking your quizzes, going back through the book and looking up those ones that you missed. For those of you who haven't taken your quizzes, you've got to do that. Okay. You're going to start getting behind. We're starting getting the weeds here with some of the medical stuff, and you're going to need that time to look through stuff. So make sure you go through there and take those first few quizzes. The class code for tonight is R0005. 1, 2, 3, 4, 5. R0005. All right. So, like I said, you guys review this one, and we'll see you again. Thursday is canceled, we're gonna wait on Thursdays, and we'll catch it up on next Tuesday. Okay. So next class will be next Tuesday, same time, same location. All right, you guys be safe during the storm. If you guys need anything, again, I'll be available. Rob and I both will be available to you over the next several days. If you have a question, just shoot us a message, and we'll make sure we get back to you as soon as we can, or as soon as the hurricane allows. So, all right, guys, you guys have a good night.